Welcome, and thank you so much for joining this meeting. It is my true honor to provide this welcome and to introduce you to this distinguished and truly exceptional panel of speakers. My name is Ann Borns, and I work at Columbia World Projects under Columbia Global. The topic of today's discussion, effective mental health interventions in humanitarian settings, is clearly an imperative issue, and we at Columbia Global are thrilled to be supporting the work of the esteemed faculty who will highlight their efforts in this area and the goals they are working towards. Columbia Global brings together major global initiatives from across Columbia University to advance knowledge and foster global engagement. One of the core missions of Columbia Global is to work with faculty, researchers, and students in partnership with external collaborators to share the research and scholarship of Columbia University that will lead to actionable social impact. We are doing this across numerous programs at Columbia Global, and the panelists will talk about their work on a few of these initiatives. The Amman and Istanbul Columbia Global Centers and Columbia World Projects have collaborated to bring this meeting together, and it is now my pleasure to introduce the panel. Lena Verdelli is an associate professor of clinical psychology and the chair of the Department of Counseling and Clinical Psychology at Teachers College, and will be framing the discussion and moderating the panel. Charlie Branos is the Gelman Professor of Epidemiology and Chair of the Department of Epidemiology at Mailman School of Public Health. Anandita Dasgupta is an Assistant Professor of Sociomedical Sciences at Mailman School of Public Health. Claire Green is an Assistant Professor of Population and Family Health at Mailman School of Public Health. Sarah Nucky is a Clinical Professor of Human Rights at Columbia Law School. And before I turn this over to Lena, I would like to thank our wonderful colleagues at the Amman and Istanbul Global Centers and Columbia World Projects for all the work that has gone into putting this meeting together, and to the panelists who you will now hear from. Thank you so much and enjoy this meeting.
Lena, you need to unmute and repeat.
Yes. Such a pleasure to moderate this panel. I've worked with a number of you over the years, and I'm very familiar with everybody's work. So let me start with a bird's eye view of the complex state of mental health in humanitarian settings today. So on one hand, there is a large body of work on understanding mental health needs, priorities, but also developing resources for the mental health of forcibly displaced persons. From global guiding tools, frameworks, and resolutions and commitments. And on the other hand, we have these very sobering economic realities for implementing services and research in humanitarian settings. First of all, we have the latest count, 117.3 million forcibly displaced persons globally. There was a slight drop because of some repatriations from 122, the peak in last summer, 2024. We all know the mental health needs of people who went through adversities before, during, and after, right? They flee forcibly their land. WHO estimates that twice as much, of mental health conditions in humanitarian settings as in population not exposed to that type of adversity. And when that conflict is protracted, and when in my field we call exposure to toxic stress, it's higher. Again, I want to underline that a lot of people, the majority of people, are, manage to adapt to these very difficult situations. But let me start with the exciting news. Many of us were in the UN September meeting, where there was, for the first time, a high-level meeting, at the heads of state level. And the first time they identified global health, global mental health as a priority in the global health agenda. That has never been the case. There are global commitments, political and financial commitments from member states to implement the policies and programs, and they focus on youth mental health, suicide, decriminalization, and prevention, regulation of harmful industries, and others. And they also, and something that I think your projects highlight this, they advocated for integrated approach, right? The meeting, it was the strong link between non-communicable diseases and mental health was recognized and became explicit. So that necessitated integrated approaches to care. And also there was, this publication showing that this is not, mental health versus business, right? It makes good health, good sense economically in terms of, the business, global business. For every dollar invested in expanding mental health programs, that there is a potential to generate a global economic return of 5 or 6 in GDP growth. For every dollar, we'll get back 5 or 6. McKinsey Global, coordinated this research. We have more than ever a lot of randomized controlled trials in humanitarian settings to determine effective and useful, relevant mental health intervention practices and tools. Tools and resources by the World Health Organization for promotion, prevention, treatment in humanitarian settings, from guiding first responders to support persons affected by crisis to case identification and management of the conditions that are more prevalent in humanitarian settings, like MHGAP, Humanitarian Guide, for example. A number of psychotherapy manuals, including ours, translated in many languages, right? And from WHO and available globally. Tools for adaptation, training, and delivery of these interventions so that the teams around the world can do this work independently, don't have to depend on us. So implementation guides. So many of us have trained not specialists, but non-specialists, lay counselors who deliver these interventions very competently with clinical oversight. We have now digital tools, AI revolution, right? Both provider-faced and patient-faced tools. Integration approaches to health networks and health routes, but also other systems, formal and informal, community groups and systems like livelihood, employment skills, for example, integration with protection programs, peace-building programs, disability inclusion guidelines. So this is the amazing news for today. The difficult news, we all know. Funding was slashed. What was the result? We get the news every day, hundreds of thousands of people in refugee camps and urban pockets have no mental health care. Badly needed mental health care is not available. Medications, life-saving medications. People and teams that have been trained over the years, they are not available anymore. They lost jobs. So it's even more urgent and pressing, essentially, to have mental health tools and programs that are that promote local independence and empower communities that not just integrate local voices, but are guided by local voices. Bilateral knowledge sharing, where, the global South is going to teach the global North and has been teaching the global North valuable skills share tools. So let's start with your projects. All of your projects actually have elements of what we just discussed and address all these urgent needs. So can you start? First of all, what are your reasons for addressing mental health in your projects? And what are your approaches to your research, scholarship, and programs? Charlie, would you like to start?
Sure, Lena, thank you very much. And thanks to you and Ann for inviting me and everybody else here. It's going to be a great discussion. So again, Charlie Branis, and my background is in emergency medical systems and disaster response. And a lot of my motivation for this stems from the work I've done in Central and South America, particularly studying the impact of civil war in Central America, mostly in Guatemala, and the implications that that 36-year civil war had for migration up through the Central American Isthmus, and the dangers and the challenges that people have, both physical trauma, but also the challenges to their mental health that they've had in that context over the decades. Now, one of the things in that context that I've learned is there's some great work that some economists have done. Anke Hoffler is one of them, which one of the great statistics that came out of that, very important statistics, not great, but important, is that of the poorest billion people in the world, 75% of those people either are in active civil war situation or have been in escaping a civil war situation in the past 5 years. So this sort of instability, extreme instability, and extreme threat to life, of course, drives many mental health challenges, but also drives a lot of movement, understandably so, across the world. And it's one of the things that brought me into thinking about what we call the Healing Roots Project. And I have to thank the Athens Global Center for their partnership on this. And I very much have to thank the University of Ioannina in Greece, who are our primary partners there in this. And Dr. Evangelia Zani is one of the professors of epidemiology, actually the head of department in epidemiology, just like me at Columbia, at the University of Ioannina. And we've just had a wonderful relationship with them, starting a project that we call the Healing Roots Project, which looks at migrant populations, relocated populations that have come into Europe, actually, and those that are trying to get into Europe. And Greece is a primary location for folks to come into Europe, by far, actually, over the years. And traditionally, that over the past decade, that's been a lot of people coming from places like Syria and Afghanistan, although this past summer, the Greeks have had a number of migrants coming in from Northern Africa as well. So there's a lot of people landing in Greece. And the EU rules are such that that is where the decision needs to be made. Now, those decisions have become much more difficult and much more challenging for folks who get into Greece. The laws have changed, perhaps in a different direction than the way they've been these past years. But what we really wanted to do with folks like this who have left such the journey is utterly challenging, and the situations they've left, as I said, in their home countries are utterly challenging to their physical and mental health. And our goal is to focus on the mental health aspect of that. And with the University of Ioannina and the team there, it was just wonderful. We're looking at what's called an evidence and gap map for the Healing Roots Project. And that is an attempt to look at all the different mental health interventions that have been studied and are out there in the world, specifically applied to migrant and relocated populations, and to come up with which ones of those, well, an evidence and gap map will show us which one of those have value and are actually have been shown to be meaningful and effective. But also at the same time, the G is gap in the EGM, and it'll show us what we think is really important in terms of perhaps mental health outcomes that don't have much evidence and where we might launch into something. With that, we have been connected to two particular sites in Greece. The one is in Epirus in northern Greece, a site called Katsikas, which is a relocation facility. And so there's an opportunity there, as well as a facility, a newly formed facility after a terrible fire on the island of Lesbos in Greece, near the Turkish coast. And so between those two sites, the hope is to learn what the evidence and gaps are, and perhaps to then test some new connections, some new sorts of interventions, and learn what does work for folks in those two sites. And that's our hope with our partners in Greece. And I'm just going to end by saying there are unique challenges about these sorts of mental health interventions on mobile populations. And I'm hoping, and there are folks here who are going to speak right now who have more experience than I on this. And I'm hoping we have a good conversation about that, because this isn't, these aren't mental health interventions that are applied the way I think a lot of people in developed nations think that they are applied. These are very difficult and austere conditions, and the hope is to do something meaningful and effective for folks as they transition on into places like the rest of Europe. And I'll stop there and hand it over to the next person.
Thanks, Charlie. Claire?
Sure. And yeah, thank you for inviting me to be part of this panel. This is an incredible collection of projects, and it's a privilege to be here. So as far as my reason and motivation, Lena, to your initial question, I think mental health problems are certainly some of the most prevalent and persistent problems in the aftermath of an emergency. And certainly, as you had mentioned, Lena, in your introductory remarks, certainly there are major gaps, and the needs are not met, I would argue, in most complex emergencies. And I think on one hand, what motivates me is, of course, to try and alleviate the suffering and the functional impairment that is caused by mental health problems. But even more so, I think it's really important for us to see mental health as one of the critical investments to promoting recovery and collective resilience in the aftermath of an emergency. So our project, and the one I'm talking about today, is one that's supported by the Columbia Global Resilience Fund, which was established in 2023 following the devastating earthquakes in Turkey that displaced more than 660,000 children and adolescents. And in Şanlıurfa, which is one of the hardest hit areas in Turkey, adolescents continue to face housing instability, disrupted schooling, limited access to services, and unsurprisingly, we're seeing a high level of distress and unmet mental health needs that, due to the destruction of critical infrastructure, the services that were there before aren't there now, and they're still trying to keep up with the demand for meeting the mental health needs of these youth. So our project, we call it the Ascent Project, is also led by my colleague, Dr. San Lau, and it's a partnership between Columbia's Care and Protection of Children, or CPC, Learning Network, and Maya Vakfe. And Maya Vakfe is a Turkish NGO with deep roots and a long-standing experience in community-based psychosocial programming. And the goal of our project is to understand whether and how a low-cost evidence-based intervention called EASE, and EASE stands for Early Adolescent Skills for Emotions, how it can be scaled in earthquake-affected communities. And this is an intervention that was developed and has been previously tested by WHO and UNICEF for children in emergency settings. So our project specifically has three core components, which I'll summarize briefly. The first is pilot implementation. So we are preparing to pilot EASE with a group of adolescents and their caregivers in Şanlıurfa, and we are evaluating the feasibility, acceptability, and early indicators of effectiveness, both in terms of symptom reduction and broader psychosocial outcomes for children and their caregivers. And then we're also doing some implementation research to understand how scalable this intervention is, not only within Şanlıurfa, but in other regions affected by the earthquake in Turkey. And we're working closely with other NGOs like Save the Children, with the WHO office in Turkey, and other local academic institutions to understand and learn from their experience with EASE and other scalable psychological interventions. And the final piece of this relates to system strengthening. So we are working very closely with our NGO partner, Maya Vakfe, to build kind of their expertise in this type of intervention, and also to collectively develop contextually tailored intervention materials that we can then make publicly available for others who choose to use them. And I'll just end by summarizing really that the ultimate aim of this project is for us to generate evidence and practical guidance for scaling ease in earthquake-affected regions in Turkey and to contribute to global learning on adolescent mental health in displacement and disaster settings. Thank you.
Thank you, Claire. And now I want to hear from Anindita.
Wonderful. Thank you, Lena. And thank you, everyone. There's so many people to thank, but in the interest of time, I'll keep it short. So I'm Anindita Dasgupta. I'm very happy to be at the School of Public Health. I will talk a little bit about some work that started with my colleagues at the School of Social Work, where I was before I joined the School of Public Health about a year ago. And so I'll talk a little bit about our work called Aspire. I think one thread among us so far is that we've got some catchy acronyms across all of us, so I think that's kind of fun. The Aspire project was funded by a couple of things, but primarily by the President's Global Innovation Fund at Columbia University way back in 2016. And I'd be remiss to not acknowledge our incredible collaborators, Nabila El-Bassel at the Social Intervention Group and Neeraj Kaushal, who really, we worked together to really lead this work. And so we ended up at that time really just looking to do a very broad assessment of sort of what are the gendered health and mental health needs impacting Syrian refugees in Jordan and in Turkey. And this was a very broad question at the time. There wasn't a lot of evidence-based, rigorous epidemiologic research that was going on. I mentioned that I was in the social intervention group. We are intervention scientists, and that's my background as well. But when we started as strong epidemiologists and intervention scientists, the first step is always that piece around assessment. And so we, as academics, took the privilege, our privilege of pausing and trying to build assessment tools. And this really came from long conversations, from visits with colleagues, many conversations facilitated by the global centers in Jordan in particular. And really we worked closely with partners, I always say the UN alphabet and NGO system about what is the most important needs. And so really what we heard over and over again from organizations was, at the time, really the need was to find out what was going on in terms of health, mental health, gendered health, inequities, intimate partner violence among Syrian refugee women living outside of camps in Jordan. This was the ask, and so we delivered. We conducted a cross-sectional study of 507 refugee women, Syrian refugee women living outside of camps. And we made it very broad, and we worked incredibly hard on our mental health assessment tools, and that's something I can comment about later. I think is the thing that I'm most proud of for the study. I am not an Arabic speaker, and so I quickly learned that there is a huge difference between spoken and written Arabic, and that had huge implications for measurement. And so we worked. I would say it pushed our timing back almost 4 months to really work hard on developing measures that were really strong and culturally appropriate while also still maintaining psychometric properties. And so we used standardized measurement tools around mental health, depression, anxiety, and PTSD. And what we found was pretty staggering. We found that almost half of our sample, again, 507 Syrian refugee women, met the criteria for all 3 mental health disorders: PTSD, anxiety, and depression. And we've published a number of papers on this. It's all online by our incredible team. And what we also found was really interesting, I want to highlight, is that we found about 20% had reported an unmet need for mental health. And we define this really as looking at people who indicated that they needed mental health services. They knew that they were available, but they were not engaging in those services. And one of the biggest key points here, we also saw a lot of factors associated with the usual things that many on this call and in the audience, I'm sure, would expect: intimate partner violence, as well as other post-migration living stressors. The other piece that I want to highlight is that we did this in strong collaboration and partnership with many different organizations, academic partners at the incredible Faculty of Medicine at the University of Jordan, Dr. Maisa Hadra and Raed El-Qaeda and Ruba Jabar. And with this group, we had an incredible concept of thinking through what implementation could look like. And so we were working very closely, in addition with our academic partners, with IRC, IFH, incredible agencies. And what we did find is that when we looked at data collection and sort of associations at each clinic separately, we found that actually those women had the least unmet need. They were at one of the clinics, one of the IFH clinics, Institute for Family Health, that had the best both intimate partner violence services and psychosocial services. And that's not surprising, right? And so, the data collection wrapped up in 2018. This was some time ago. And I know there's been a lot of discussion about integrated methods around mental health and other issues. But in that situation, it really did help, right? What IFH was doing was working. And so that's one major contribution. And I know I'm running on low on time. I just wanted to briefly mention that through this Aspire project, we also were funded to do a small bit of work in Turkey. We were funded to do actually the same sort of thing, to do a cross-sectional study. But given what was happening in Turkey, this was right around one of the coups, we noticed that our service providers and our collaborators at the many different universities there, they were struggling themselves. And so we paused and we did a small mixed method study. I mentioned this was when we were at the School of Social Work. Great wealth of social workers there who work on secondary traumatic stress. And so we did a small mixed method study with about 100 people who give direct services to Syrian refugees. And again, this was also in 2018. And what we found was that of the people giving direct services, whether they were social workers themselves, translators, providers, different services, almost half also reported meeting the criteria for depression, anxiety, and PTSD. So these are just some minor points, major points from our studies, and I'm very happy to talk more in the discussion. Thanks so much.
Thank you, Anindita. Sarah?
Thank you. I'm coming to this set of issues from the field, from the perspective of international human rights law and advocacy, and initially came into the issue of mental health from my work as an advocate working around the world, investigating human rights violations, especially in war zones, and seeing the mental health impacts on activists doing that work, and of course on the civilians living through war, seeing their mental suffering, but also seeing the lack of attention to mental health within the human rights field. And the interest grew from those direct experiences. In the human rights space, mental health often receives less attention than other human rights issues. It's often sidelined or seen as less of a priority when stacked against other issues, even in contexts where mental health concerns are so clear and so grave. In armed conflict settings, for example, we tend to see much more attention by human rights actors and international justice mechanisms to physical violence, on investigating and conducting advocacy around violations of human rights and the laws of war that cause death or physical injury. And there's often less understanding in that space and less attention to health broadly, including mental health specifically. And this is despite all the work that colleagues in public health and humanitarian settings are already doing on mental health, and the large body of research that shows the long-term effects of mental health harms. So given that backdrop, our law school, human rights clinic and center have engaged in a number of investigation, research, publication, and advocacy efforts around the right to mental health, to bring a human rights lens to mental health, and also to bring existing mental health research into human rights practice. So this work has included efforts to improve understanding of the right to mental health impacts of armed conflict on civilians, what they are, why the right to mental health is incredibly important and not less urgent than other important rights and needs. It's also included building understanding of the legal issues at stake and the legal duties of states around mental health issues. And then it's included attention on the mental health of activists, particularly those working in war zones where they, of course, face heightened insecurity and threats and lack of access to support. So I'll say a little bit about one of these partnerships, which was around the mental health impacts of the armed conflict in Yemen on civilians. And we worked with a leading think tank in Yemen called the Sana'a Center for Strategic Studies, who we've partnered with for over a decade on a range of human rights and justice issues in Yemen. They brought the mental health concern to us and said that we're seeing among ourselves, our colleagues, and the broader society intense mental health impacts after the years of war. It's not talked about much, however, it's not getting much attention in policy spaces. And they said, could we study this together? Could we bring different disciplines together and seek to set or shift agendas at the policy levels, the national and international policy levels, to raise the profile of mental health and attract more research, attention, and reform efforts to it. So we built together an interdisciplinary team of mental health, public health experts in the particular context of Yemen and its war, with human rights, legal, and advocacy. And we ended up producing a report that we used for advocacy purposes. And the report was showing the seriousness of the mental health issues in Yemen and why policymakers should care much more about it, and why it actually entailed legal duties for the state of Yemen as well. The population there is severely stressed from all sides: indiscriminate attacks, airstrikes, landmines, the use of child soldiers, torture. Almost half of the population faces acute food insecurity. There's blocking of aid. Almost 5 million people remain displaced. There's unemployment, cholera, and so on, including widespread atrocity crimes committed against the civilian population. And we brought into the report some of the existing scientific research into the legal and policy spaces. That research shows that approximately 20% of the population suffers from mental disorders. One study suggested that almost 80% of school-age children in the capital, Sana'a, report symptoms of PTSD. And currently, an estimated 7 million people face psychological trauma and stress. Despite these needs, however, when we looked at the infrastructure and the policies and the laws and the systems, there are few and quite poor quality mental health services, maybe 46 psychiatrists across the entire country, and few of the primary healthcare facilities had staff trained in mental health. And then the general state of the healthcare system made much worse by the ongoing armed conflict, with many health facilities not fully functional, workers not having their salaries paid, and medications in quite short supply. So we then worked with our colleagues in Yemen to build recommendations for the government, for researchers, for civil society, for donor countries, for the UN, to support policy and institutional change related to mental health. And then working together, we pushed these findings out into those spaces with the recommendation for much greater attention on mental health by policymakers. And perhaps I'll say a bit more about what those advocacy efforts were and how we combined our expertise to try to move them forward. Thank you.
Thank you so much. Your projects are even richer than from what I was reading online and what I've talked to you about. I'm always amazed by the richness of the work. Let me ask you about academia, in our case, Columbia University, right? How can Columbia assist in shaping research, practice, and policy for community recovery and development of mental health systems, but the type that is locally relevant, sustainable, and empowering? And if you can give us examples. Claire, would you like to start? Only because I've worked with you and I know some of these specific cases.
Sure, I'm happy to start. And thanks, Letta. I think this is such an important question because as you kind of started off with this webinar, we're at this moment where there is unprecedented need, but at the same time, global funding and resources are contracting. And I think what I have seen so far and the discussions I've heard so far as in terms of what that means for mental health and psychosocial support in humanitarian settings is that the humanitarian system is really being pushed into hyper prioritization. And I think this makes it even more critical for us to think not only just what is being implemented and is it evidence-based, but positioning it to achieve real-world impact, which I think, as we all know, goes beyond just the evidence. It's about the partnership. It's about the communities. It's about how we position and how we think about these interventions existing within broader systems. And I mean, one of the things that I've been reflecting on recently is I do think as academics, we need to be honest with the fact that despite the last 2 decades of investment in research in global mental health, we still don't have good examples of effectively reducing the population level burden of mental disorders and mental health conditions. We have effective interventions, but I think there are 2 major gaps that persist and are really critical for us to think about right now. I think the first one is the implementation gap, making sure that the evidence-based interventions we have are reaching those who need them the most. And I would argue that right now they're not. I think we continue to struggle with scaling what works in smaller research studies within broader systems. And I also think many of the programs that we have evidence for, are difficult to deliver in systems that are under-resourced and overstretched sometimes. And of course, there are exceptions to that, but I think we need to be mindful going forward about that implementation gap. And then the other piece that I think is really important is the social determinants gap. So we hear repeatedly from the communities we work with about the salience of the structural and social drivers of mental health conditions to people's well-being, things like violence, discrimination, job insecurity, social exclusion. And in general, I think these things have largely remained untouched by some of the more traditional mental health approaches. But when they're the things that displaced populations consistently identify as the factors that are contributing to their mental health or poor mental health, I think it's important that we are mindful of that. So when I highlight those key gaps within the context that we're currently living in, I think these 2 forces are really coalescing to push us toward 2 things. And one is localization approaches. I think now we have been arguing for this for some time, but now there's really no other choice than having services be community-led or led and implemented through national systems, which I would argue, and from what I have seen in some of our kind of community-led mental health intervention work, can really lead to interventions that are actually more fit for purpose. The second one, and Lena, you also alluded to this in your opening remarks, is I believe that this decline kind of in funding and the recognition of the importance of social determinants will also push us toward more multi-sectoral and integrated approaches that do draw in kind of the economic determinants, violence, et cetera. And just one kind of brief example of this is we had recognized in some of our work in Latin America that one of the biggest barriers to refugees and migrants engaging in mental health services was kind of whether they had a reliable income source. So one of the things that we ended up doing is we integrated evidence-based mental health strategies into a poverty alleviation program, and retention jumped from 50 to 90% because no longer people were having to choose between whether to participate in a mental health intervention or to engage in income generating activities. And I think, I know I've been talking for a bit too long, Lena, I'm sorry, but I do see that there are some kind of critical roles for academia in this work. First, to generate actionable evidence that can guide us through some of these shifts, to promote bidirectional training and exchange and have that truly be bidirectional. But I would argue that the most kind of the important responsibility we have is one of convening and amplifying voices from communities, because I personally have a worry that with the kind of decline in multilateralism, the rise in nationalism, a lot of the spaces that we're seeing where people can share what they're learning and what they're doing are becoming constrained. And I think that is the power and responsibility we have in academia to promote those spaces so we don't lose the momentum that we have in global mental health. And I'll stop there.
Yeah, thank you very much. And your point is so well taken. And to add to this, the integration within, for example, livelihood activities also destigmatizes, right, the offering. It's a non-stigmatizing setting where people can go and get mental health care. And that also, what you said, we need to reflect on authorship and whether, we promote local voices and local colleagues, right? Who would like to
Lena,
continue?
can I add something on that?
Please, Charlie, yeah.
So I want to zoom it out a little bit and think about what is the value, and to a number of Claire's points, what's the value of universities and the entire academic community? Frankly, the word academic and the idea of academia isn't well received, particularly in these most challenged settings. So when we think about it, I see a couple of things, and I think one thing is providing evidence of what works, studying it and learning about that, and then learning how to distribute that. I think that's a good value of universities. But the other is, there's a global network of universities and people in universities in nations. Every nation around the world has some kind of academic culture. And it's amazing when you connect folks from the various academies, universities, colleges, whatever it may be, in various places around the world, there are huge opportunities for local input that might emerge from the local university. And so for us, like for instance, at Columbia or any like US-based institution, we should of course be connecting with local academics at every opportunity. They're basically in our field and working in that network. At some level, the universities also provide programming. But it's really only the past years I've begun to notice, especially as governments are pulling out of the business of providing services, particularly mental health services in nations, in some of the most challenged places and some of the most challenging facilities around the world. I've begun to really notice the critical value of non-governmental organizations and of NGOs and what they're doing, oftentimes with almost nothing. And I think that our NGOs and, secretly, a lot of these government agencies will tell you behind the scenes that it's really always been the NGO doing the work, not them. And I think we need to begin to recognize that and have more of a connection with our NGOs, elevating them and getting our universities to connect with the right NGOs in the right spaces to offer as much as we possibly can as a team.
Thank you, Charlie, which takes me to the next question. Like, what's the impact on, like, the real world impact question, right? So let me ask Anandita and Sarah, what approaches or models have been most effective in turning your work into real world impact and tangible impact? If you could highlight, your biggest challenges and ways you overcame those with your colleagues around the world. Anandita, would you like to?
Sure, I was going to give it to Sarah since I saw her hand for a second. Sarah, do you want to go?
Sarah, please. Yeah.
Sure, I can. Thank you. It's such an important question, and some of what I would say about it overlaps or re-emphasizes points made by my colleagues just now. There's a lot of ingredients that go into turning research into real-world impact, but maybe I just highlight two of them. One, from my experience, that thinking around leadership and partnership that directly affected people, that experts, researchers, civil society from the affected area, that they're leading the identification of what the problem is and what the needs are. They very often don't need any kind of outside support from academics, and there shouldn't be an assumption from the start that that is necessary. But where rights holders and local experts do identify that those kind of transnational partnerships would be helpful for their goals, then I think outside actors can play a really helpful supporting role where they follow the lead of those closest to the issues around what the problem is and how to understand it and what to do about it. With some other colleagues from the human rights field, Anjali Paran and Gulika Reddy, we actually did a global study of North-South partnerships and of the power relations in those partnerships. It'll come out as a book later next year. And one of the most commonly reported problems from countries all around the world continues to be the dynamic of the outside advocate coming in, seeing themselves as holding expertise, not sufficiently understanding or even recognizing local expertise, and then trying to solve the problem from outside. And of course, this leads over and over to work that is either poorly tailored to the actual needs or even can backfire. So as an example, in our work in Yemen, when we came to formulating policy recommendations, what to do about the really serious mental health stressors the population faced, some recommendations were focused on mental health specifically or sort of the symptoms. For example, a recommendation that there should be more training for producing larger numbers of mental health experts in the country. But our Yemeni colleagues were really insistent that among the top recommendations were those directed at the state and what it was directly doing to cause the mental health issues in the first place. So that meant key recommendations were around the fact that the state was not paying salaries to public sector employees, and that non-payment of salaries over many, many months was causing mental health stresses in the first place. And so their local expertise about what policies, what actions were causing mental health in the first place allowed recommendations really tailored to the local context. And then a second, I think, key ingredient for impact is that the goals, the long-term goals are driving the research from the very beginning, and that there's a theory of change. Why is research needed? What's the gap that it's intending to fill? How will that research or that evidence be used to persuade advocacy targets or make an impact? And that long-term goal has a theory of change, understanding who has what power to make change is coming in at the very design of the research phase.
Thank you, Sarah. Anintita?
Great. So I mentioned before that we focus on intervention science. That is my background. And so the Aspire project was epidemiologic in nature. And my instinct was sort of, once we got the findings, which did highlight mental health being the primary need and driver of every single analysis that we did, whether we looked at reproductive health, whether we looked at chronic disease, mental health over and over again was the primary driver. So my instinct was to jump into intervention, right? That's what we do often as academics. But one of the things that we did, again, often a lot of this was facilitated by the Global Center and our incredible partnership with academics in both countries as well as NGOs, was we really took our time for dissemination. And I don't mean lowercase dissemination that we often talk about in academia, where we publish a bunch of papers, we do a report, we do an event. We did all of that. We checked those boxes. Many a dissertation has been written off of these data. Fantastic, right? But what I really loved about this work was we sat and we talked with our collaborators at the NGOs, and we broke down the analyses based on what they wanted to know. We did this data, the Women Aspire study, at 4 different clinics with 2 different agencies all over Oman. And the results were really different for what each subgroup of women were experiencing at each clinic and at each organization. And some of those findings don't need to be public to everybody, right? That is the work that we can do to sort of highlight, okay, well, this is what we think we found, is working based on the results, and being very careful about causality, but really just showing, okay, this is the cross-section, this is what's happening right now. And one of the things, and part of our impetus to do that study to begin with was one of our colleagues had said at one of these organizations had said to us, we know that violence is happening. But we have such a strong relationship already with so many of the women coming into our clinic for services, they are not going to disclose to us. But you know who they would potentially disclose to? A bunch of relatively neutral research staff who we were able to train around research methods, right? And using evidence-based, rigorous, culturally tailored psychometrics to get the answers that were needed to help inform the practices that these organizations were doing. So we really took our time, and it even involved sort of, our team of students, both at the University of Jordan, the medical school, which was really exciting, as well as students at Columbia, both at the School of Social Work and Public Health. And we played with numbers in front of them in real time to say, okay, let's figure out what's going on with this specific group of people. And there's only so much that you can really pick apart with that much data, but we still were able to provide some answers to the questions that the organizations had. And many of the organizations were already doing really incredible work. So that's one piece. And then the second piece I just want to highlight kind of goes back to the first question around academia, but I think also important in terms of what's effective in terms of strategies. Sarah mentioned this briefly, but investing in the next generation of students, right? We are in this time, as we've all talked about, with really stressful funding situations, but we are also losing out on an entire workforce, whether it's mental health, public health, social work, all of these worlds, right? So this was an issue even prior to these major funding issues, right? We've all been hearing for many, many years, there are not enough formally trained mental health professionals in each country, right? And so what does that mean in terms of sort of professional schools and training? So I think we've had really great success with that. We've loved working with students across all three countries and across multiple disciplines. And it's been really, really incredible to see that. So I want to highlight that and sort of the joint collaboration. It took effort and time, different cultural contexts and different disciplines, medicine, social work, and multiple spheres of public health. Takes a lot of negotiation, but we all learned from each other. And I think that was really huge. And I think that has led to really great collaborations moving forward. So just thinking again from a broader perspective of investing in this next generation is going to be key. We don't want to lose out on this.
Thank you, indeed. It's actually a very important point, right? The next generation of mental health programmers and researchers and policymakers. So let me now go to the very, thoughtful questions that we got from our audience. And I can see here a number of them focusing on the cultural relevance and ecological validity, but even the usefulness of many of the categories, the diagnostic categories we use, right, the Western ones, in these settings. And to take it a step further, what is normative when there is toxic stress, when people, have no respite and they cannot recover from, the mental health, right, from the adversities. Could you reflect on that?
I'll try to answer that. And I think that a number of the questions that I'm reading in the Q&A are around, I think they relate to what Sarah was saying and what you were saying, Lena, about mental health being less of a priority, particularly in the context of, so Sarah mentioned, if salaries are not being paid, right? Or if it's in a war context. It's very difficult without settling these very fundamental structural challenges to then launch into some sort of mental health improvement program. So I say that, and I think we have to recognize that and begin with that as a statement. And perhaps there are other things that aren't as directly focused on mental health that need to be addressed first before we launch into these. That said, you started by saying, Lena, that the economic return for mental health programs, I think, is like $5 for every dollar that's invested. And I will tell you, as someone who looks at broad opportunities to address situations of challenge and disaster, that's very good. There are better returns on investment in other types of programs. And I say this because I really think that particularly academic mental health research and the academic community perhaps sometimes overcomplicates what they want to achieve here. And the options could be, especially in these very challenged contexts, the options could be to begin to think about things that are not so complicated. Lay counselors were mentioned, community mental health workers, the local providers, and the importance of incorporating local providers not only enhances the potential impact and effectiveness of what will be done, but it might actually make that return on investment much, much, much higher. And I think we need to start thinking about not overthinking and not overcomplicating, but in my experience, the best interventions are the most straightforward and the least complicated, that involve local folks and make the use of whatever resources are already in place.
Could I add to
Claire,
that briefly, Lynn? Thank
please.
you. Yeah,
Yes.
no, great points, Charlie. And I think I'm also noticing that there's a question about, specifically in the context of Gaza, how do you respond to people's mental health needs in that setting? And I think in a very acute emergency, there is a population of people with pre-existing and very acute and severe mental health needs that must get care. And or people, for example, who have been on medications for years, who now access to those medications have been disrupted. I think there should be a prioritization of making sure we provide continuity of care to those people. But I think to Charlie's point too, what in that specific moment, in a very acute emergency, coming in with a kind of pre-cooked mental health intervention in that setting may not be the right decision. But one thing that I've kind of learned through many moments of realizing my assumptions about what would be appropriate have been very wrong, is that there are elements of the evidence-based strategies that we have that can be useful, but it's just, I think, much of the how we deliver it that matters. So just a quick example, in some of our work, and Charlie, you alluded to this earlier, focused on providing mental health supports to migrants while they're in transit, while they're on the move. We've done some work throughout migrant shelters in Colombia, where people stay for a maximum of 3 days before moving on to the next place. And this is true in many kind of migratory contexts throughout the world. And one thing that we've learned through asking migrants what it is they need to support their mental health, it's things like navigating the uncertainty of knowing kind of what's next, managing the risks associated with their migration, giving them access to information so they can make informed decisions about how to move forward. And I think a lot of the strategies we have in our mental health toolbox can be used to support those things. It just might look a little bit different than our kind of traditional 5 to 10 session therapies. So I think we can draw from some of those, but they might not be totally appropriate in their current form in some of these very acute settings. And I agree with what Charlie said about trying to address some of the kind of sources of stress might be the most important in some of those moments for the majority.
So I think it's time to start wrapping up. Let me find out, actually I think we have 10 more minutes. Wow, that's great. Because there is a very important question. I know many of you have not only thought about it, but done research on this. We say effective mental health interventions. But what do we mean by that? Especially about the sustainability and the long-term effect. Do they fizzle out after a while? And what do we know about this? Because it's like building and demolishing at the same time. If we have something with do we have good mental health inoculations, life inoculations for this? Who would like to start with this one?
I can chime in.
Right. Yeah.
if that works.
Yeah, and indeed, yeah.
And Charlie, I'm not just throwing this to you, but I do think that your project around mapping and the gaps, I think, is a great example of what we need to be doing. I think others on this call have also talked about this. I think finding the first taking a step as academics, this is one of the things we can do. Charlie's already doing it. Gathering the information about what tools exist and what is working. And something else that Claire had mentioned in terms of implementation gap has really, it's been something that I've thought about a lot as well for evidence-based interventions and impact over time. You've heard me say a few times, a lot of these organizations are already doing incredible work. There's already really great mental health work going on. But I think one component, and I think this is part of implementation gaps as well, is evaluation. And I think helping organizations in particular, this is something that I've heard, whether it's in the Middle East or South Asia or Central Asia, is understanding how to build in evaluation of programming that is already in place in a rigorous manner, right? Maybe potentially thinking about, as much as I love a randomized control trial, thinking about what that can look like in a true implementation science perspective. And the other piece, again, I mentioned the metrics and the psychometrics, and I think there's a question in the chat a little bit about this, but making sure not only that our interventions and our programs are culturally tailored, but also that our evaluation measures are. I think we're missing a lot by not spending as much time in the psychometrics field. This is not my area of expertise, but there are many who do this work to think about how we measure mental health burden for different contexts. I think there's not enough focus on that. And so I think as we are talking about long-term effects, I think some of the main questions are sort of how do we measure and what are we measuring are really key as well.
And just to add to this, there are all these great models now in using, rapid ethnographic assessment, for example, Paul Bolton's work on identifying local idioms of distress, and validating Western instruments using these local idioms as a gold standard, right? So how to marry those two Western and local approaches, or develop. There are sometimes, where nothing really makes sense, and you have to develop your own instrument. And there are tools also globally available to help, the local teams develop their own locally meaningful tools and scales.
Lena,
Policy. Yes, Charlie, please.
I just want to further recognize the question and the questioner that was put in the Q&A, and just say that I think that for our evidence and gap map, we're going to begin to look a lot, not just at the short-term impact, but I think we have a component, very much so, of what's the extended impact and the sustained impact. One of the reasons is mental health interventions and treatments and so forth can be notoriously short-lived and in need of maintenance. And in these particular settings and populations, we have a lot of conversations about this. There's no opportunity for that. So what are the implications of so to this question of, quote, what is, quote, effective? We need to perhaps redefine that in a lot of ways, given what we're studying.
So important. And then I see a couple of questions on the social determinants, right? And a number of you, like Sarah, you have done work on peace building and mental health. Could you reflect on this, the importance of addressing social determinants, and then how to translate this to a policy level intervention? Sarah, you're on mute. Would you like to take this?
Yeah, alongside the public health, psychology, programming, and interventions, I would love to see much more attention to justice for violations of mental health and collaborations between advocates and legal experts and scientists could be very valuable in building the evidence base that would be needed for this. So mental health is not only a human need, but it's actually a right, and it's specifically protected under international human rights law. Everyone has the right to physical and mental health. And that means that states have legal duties under international treaties to respect those rights. And in the context of war, international humanitarian law and international criminal law also protect against certain harms to mental health. Healthcare facilities should not be attacked. For example, certain acts that amount to mental torture can be war crimes. Inhumane acts that cause serious injury to mental health can be crimes against humanity. Mental harm is even listed as one of the acts that can constitute genocide. And where rights are violated, there is a right to a remedy that it can include compensation for damage, including mental harm resulting from gross violations. There's not much, however, when you look up at the regional or international systems for justice, for international criminal accountability, focused on mental health. It tends to come in after, if at all, as a kind of afterthought. But I do think, thinking about what might support changes by state actors, that really honing in on their legal obligations and encouraging actions that would lead to accountability for states who don't meet their obligations could be one way long-term to support the development and the strength of norms and practice around mental health.
And Claire, you have also some examples for another set of questions about, from the work I know in Peru, about local, health workers. Charlie said, a very promising, right, solution, task sharing for sustainability, and how they shaped policy. Simple women, refugee women, changed policy.
Indeed, powerful women indeed. Yeah, thanks for making space for this, Lena. I mean, we together, I think, have had the privilege of partnering with humanitarian NGO called HIAS since 2018 at Columbia. And they do a lot of really incredible work around mental health and psychosocial support for refugees, migrants, and also, importantly, host communities. And through this work, I think connecting back to some of the earlier question around sustainability, what it has taught me, and I'll get into the details in just a second, is that I think the true path to sustainability at a systems level is community leadership and ownership. I think the only examples personally that I have seen where interventions live beyond the duration of a project is when there is that sense of ownership by community or by the government or another actor to carry it forward. And so some of the work that you alluded to, or actually all of it, has been different variations of us testing this task sharing model where we train refugees and migrants to deliver different types of mental health interventions to others in their community. The work in Peru, we were testing a very brief 3-session interpersonal counseling intervention delivered remotely and trained remotely by your team, Lena, to other refugees and migrants experiencing distress. We've tested training of trainer models of problem-solving therapy interventions in Colombia, and several others in different contexts. And to highlight just a few examples of kind of, I guess, small wins in terms of shaping policy. I think one of the most powerful moments from our work in Peru was actually at our dissemination event, getting to your comments, and Anindita, where we, of course, presented our data. We presented what we found throughout the process, but there was a panel of the women who we had trained who were refugees and migrants themselves, talking to UN actors, talking to government stakeholders about their experience and the impacts that they observed. And that was the most powerful part of that entire panel. And I think it is rare that we have opportunities to elevate kind of the voices of community members who are doing truly the hard work and sharing their experience with people acting at kind of the kind of upper echelons of the government. And another example of that, very similarly with the same NGO in Colombia, we used a similar model to share the findings from another task-shared intervention. We had members of the community talk about their experience in shaping the intervention. And ultimately, the mayor of the city of Barranquilla chose to adopt that intervention, integrate it through their local health clinics, and the NGO has scaled that program to other sites within Colombia. And truly, I mean, I think the data is essential, of course, but ultimately, I think where the impact comes from is that partnership and people talking about their experience in shaping and delivering these types of programs.
Thank you very much. I think we should wrap up this very rich conversation. What if all of you have a minute each at this point to summarize, lessons learned from, for our audience? And Indita, shall we start?
Sure. Okay, 1 minute. I think for me, the biggest thing, and this is not unique, but it's the local collaboration, right? It's the partnership. And as Claire has mentioned, I think it goes so much beyond just, working together, not being bad academics of sort of getting entree into a community and then leaving and sort of not really engaging. It's true. It needs to be true partnership and understanding what solutions already exist, whether it's at the organizational level, sometimes policy, or individual level with individuals themselves. So that's my push.
Good. Charlie?
So I'm going to second the need for mutual engagement at all levels. I think that's critical, and we've written about that in the past and seen that be very successful, and not doing it be very unsuccessful, to Anindita's point. The other is, as an interventionist who does a lot of community-based intervention, that I'll restate the need not to overcomplicate the interventions themselves. To find things that are meaningful, community initiated, but that don't necessarily need to be overly complicated. And then the last thing is the conversations about setting up the basic structures and the context that allow these interventions to occur in the first place, including being invited in and the need for you being there in the first place, but things like the challenges of a war-torn environment or the challenges of an economically absolutely stressed environment, those need to be considered first. I'll stop there.
Thank you. Claire?
I love those comments and couldn't agree more. But I think the one thing I'll say to wrap up is just, I do believe that investing in mental health goes so far beyond what is happening in any individual's mind or body. And of course, that is important. But especially with a lot of, I think, the geopolitical trends happening in the world, what we really need is a restoration of our kind of social fabric and collective efficacy. And I'm a strong believer that we have the tools to promote population mental health, to promote well-being, and ultimately strengthen our kind of social cohesion. And yeah, that is what I'll end on.
Thank you. Sarah?
Thank you. In addition to these important points, I would add two. One is understanding the intersection and interdependence of mental health with so many other issues, with education, with work, with livelihoods. And the second is thinking about how to build in the time, the resources, the expertise to conduct advocacy to national and international policymakers with the findings of the scientific research, and how to communicate that research in a range of ways to reach broad and diverse audiences for impact.
Thank you, everybody. It's 11:15. And thanks to the audience for your very thoughtful, provoking questions. Take good care.
Thank you.
Thank you.